Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Aebhric. This week, I am joined by Andrew Azelton here in Malta, and he is on the eye care program and the APIS program as part of his master's program. Andrew, welcome to the program.
Thanks for having me.
So tell us a bit about yourself and what's keeping you busy.
Yeah, so I'm a Texas medic. I've been in Texas for almost 20 years, about 25 in pre-hospital. I've been a paramedic for approximately 18. And what's been keeping me busy right now is this master's program.
So you've done 1 year. So what modules have you finished?
So I have finished all except for the one I'm in right now, which is the eye care. So that's
703. So
yeah. And then the only one I have left is clinicals and working on my thesis.
So how have you liked the program? How has this helped your practice?
Yeah, well, it's been very challenging. The pathophys, disease process, and length of care that is expected of me to perform on patients is significantly longer. So everything that everything I'm comfortable with in pre-hospital is challenged. And I think that's what I like about it. It's very challenging. Being pre-hospital for so long, I'm always learning stuff, but you get comfortable. And this is far out of my comfort zone, which I really like.
So there's tons of options for you for master's programs. Why did you choose this?
Well, I started out deciding I was going to get a master's. All of my formal education is in EMS. So through the kind of U.S. education system, I got my associates when I got my paramedic. That was in 2008. And then I've been slowly working on my bachelor's part-time as I've been working. So I finished my bachelor's in EMS. And then what I found was I was looking for a master's program that had clinical placement and hands-on. And that doesn't exist in the United States as far as I know. My bachelor's in EMS covered treatment, pathophys, critical care. The only programs that I'm aware of for masters in the States have to do with public safety administration. And that's not anything I want to do. I've had some interactions with some medics from Europe, and I was aware of some master's programs that existed. So just searching through that, I came to CoROM. I think I was aware of you guys through the podcast. And then just looking at everything you offered, the fact that this is an austere placement is what really got me excited. A lot of the programs I saw in the UK were more kind of like hospital-based or something like that. And this was the only one I found that was, for those listening, they'll say you have the option of clinical placement. There's options all around the world, but the Tanzania placement and then listening to people who had already been there. So I believe right before I signed up, I listened to the podcast you did of the 2 Canadians that went there, and I was sold after that. Signed up, went through the application process, and here I am.
So there's no master's programs in the U.S. for clinical experience, clinical acumen for paramedics.
To my knowledge, if there is, I'd love to be corrected. But, what I find in Europe is the pre-hospital medicine has a continuation, and we don't necessarily have that in the States. So if I was to get a master's, it would be either a nursing or maybe a PA route. And those didn't excite me like this did.
There's a lot of controversy at the moment in the States for people like David Pfeiffer, who's trying to push for master's level paramedic. And there's just so much red tape. There's so many people out there, so many naysayers that just don't think that us paramedics are capable of advanced practice. So what will it take for the Americans to get to the same place the Australians, the South Africans, that the British have with a master's level advanced practice paramedics?
I wish I knew the answer to that. I can talk about some of the issues that I see with this. And I think, speaking as an American medic, our EMS system is very fractured. It's divided up into private, local government, and there's so many different versions of how EMS is ran that I don't think, especially with private EMS, but I think paramedics in the States are looked at doing one thing, and that's riding on the ambulance. And once you get your paramedic degree, it seems like there is, for some reason, there is a lack of advanced education. And I don't know. We have done really well getting a lot of bachelors. So when I started EMS, there was maybe 1 bachelor's in EMS. That has grown significantly. So I would love to see a master's program in the States. I think that would be great. But yeah, I have yet to see it. And you talked about David Pfeiffer. There are master's programs, but the one that I'm aware of, at least if he's working on one, but all of them seem to do with public safety management. And I like taking care of patients. I like being in that environment, and I love the challenge that like austere medicine would give me.
So in the States, you fall under the Department of Transportation. You're not even a healthcare provider. You're a transport person. Is
Correct.
that part of the problem? Is that what needs to happen? Is a magic wand to place you under the Department of Human Services?
Well, I don't know. We have a funny saying in the States, and that's I'm from the government, I'm here to help. And I don't know I think moving away from the Department of Transportation would probably help us. But then we need to ask, where are we going to, and what is their thoughts on us, and what ideas do they have? So it's very fracture is the word I keep saying. There's lots of government fracture. There's lots of private EMS systems, and it's challenging again, because when you think of Europe, especially like England, they have a single EMS system, and it's funded a certain way and it runs that way. And that's just not the case in the States.
So let's look at Kentucky. You're talking about fractured. And of all places, Kentucky has passed laws of advanced practice paramedics, as long as they have the board certification wilderness paramedic, which you do. So there is scope now for advanced practice paramedics, but I'm not sure if David Pfeiffer will be able to follow that up with a degree program, but there are advanced practice, like flight paramedics can do vast amounts of additional skills. Yeah. Why can't that happen to the street paramedic?
So it can, but I will explain you kind of the situation that I'm in. I'll tell my story because that might help answer the question. But I would say the biggest thing would be state regulation. And I'm going to give an example of where I think it goes good. So I'm from Texas. Texas is a delegated practice state. And that means that anything that my doctor can do, he can allow me to do, assuming that I am properly trained and have the knowledge base for it. So when you look at systems like Kentucky, where they're trying to move to that advance on the state level, what typically happens in Texas is we do it at the department level or county level, and that falls on your doctor. So working under Dr. Escott, Dr. Pickett for a long time, there was a lot of advancement. So when you go into Texas, we are delegated practice. So having my FPC, I'm known as an advanced practice paramedic, but that is in my department. My department has created that. And they've created that kind of step-by-step process to where you can increase your skills and have more responsibility. So I do have that. I'm extremely lucky that I get to have the advanced training and all the resources that my department gives me. But you will not find that if you drive one county over or one state over. And EMS quality, I'm not going to say the quality, but the level of care you get varies drastically on where you are.
I guess it's the same here in Europe. Your care in pre-hospital is different because in most countries, you're going to get an ambulance driver and a doctor arriving on the ambulance. There's some of us that have a paramedic. In Ireland, we have a paramedic and advanced paramedic. In UK, there's a paramedic, advanced paramedic. And here in Malta, there's nurses and nursing ambulance drivers, and they have some ALS stuff. But the difference is in Ireland and in the UK, paramedics have their own license. They don't work under anyone else's license. So an advanced paramedic in Ireland or paramedic in the UK take home their bag with drugs, products, everything, and they put it in their house. Anyone can knock on their door at 3 a.m. and they can do NARCs, they can do RSI, they can do whatever is needed because they're always their own healthcare provider working under their own license. How contentious is that for America, and how can we move in that direction?
Like, you might have saw my face here. I'm like, I'm smiling as you're saying that. How is this an issue for the States? So going back to the US, everything is ran by physician. The issue that I see with that is I have a paramedic license in the state of Texas, but I have to work under a physician. And when you do that, you are now dependent on that physician. And I would say a lot of our protocols are based off litigation and risk management versus proper care to the patient. And I think having your own license would help with that. But at the end of the day, although I do share the responsibility, it ultimately falls back onto my medical director. And I appreciate that. I used to tell our doctors, like, I don't know how you sleep at night, just laying there in the bed, thinking there's like 600 medics just roaming around the city, taking care of people under your license. So I I appreciate it. That's interesting. I actually didn't know that. So that's fascinating.
So if someone were to wave a magic wand and suddenly you have your own medical license in the state of Texas for you now, what would change?
So I think what would change for me is hopefully that would allow me to be more in charge of my own education. One big frustration I think a lot of us share, especially us more advanced and experienced medics, is you tend to repeat the same CE and the same certs over and over again. And I think having one thing that would be nice as an advanced practice medic is having a little bit more control over your continuing education. And I think that I would change that. Obviously, we would have to keep up some standards, but I think the more advanced you get, I think the more responsibility you would be given to manage your own education versus maybe EMT would be more stringent. And as you move out, you would have more ability to manage your own training. Man, waving a magic wand, that would be the big thing. And then having some sort of structure set up where we can have a pathway in the United States for an advanced practice paramedic thing. So right now that would be probably under National Registry. But again, as we talk about it, we have registry, we have Department of Transportation, we have Department of Health, and everyone has an opinion. And do you know this saying, what is a camel? And they say it's a horse created by a committee. And I think that's we have great medics, and please don't think I'm bashing the US EMS, but I think that sums it up. Like there's too many people with opinions and fears, and it tends to go nowhere. Yeah.
There is some talk in the US about having master's level nurse practitioners with an EMS fellowship, or they won't call it fellowship, and EMS ability. So you will have a FP, family practice nurse, in an ambulance, treating casualties and dispensing casualties, or a PA. So possibly a PA would work per hospital. A way to fix this problem in the US EMS of not having advanced practice. Is this a way for the US to get past this advanced practice problem by allowing paramedics to go to PA school and nurse practitioner school and get an EMS specialty?
I don't know. I'm going to say it depends. And I think it weighs heavily on who that nurse is and what their background is. So if you're asking me, they've had no pre-hospital experience and they've taken some sort of, I don't want to call it a crash course, but this is EMS. EMS is a very challenging environment to work in, and PAs and nurses can be phenomenal clinicians, but if you have never done it in the field, it is very, very different. And I think instead of finding PAs and nurses that can be advanced, I would be more for taking our paramedics and making them advanced.
I'm definitely in the same boat, but I don't see a change coming from the United States EMS system. Having it fall under the DOT, the firefighter union is profound. They don't want to lose their firefighter paramedic. And let's face it, there's a lot of firefighter paramedics making $120 a year. They don't want to lose that either. So there's a lot of red tape everywhere. But would this be a backdoor? I don't know. So the state of Texas suddenly said that, all right, we now have a PA EMS system for prior paramedics who've gone to PA school, and they're the only ones that can be these PAs. Actually, that's not right, because PAs still work under a medical doctor. Right. The NPs do not. So it has to be one of these many shake and bake NP programs where if you have a bachelor's degree in underwater basket weaving, in 2 years, you're a nurse practitioner. That's scary, isn't it? But if we do that just for 10-year paramedics, would that be an option? So if we were to design an advanced practice paramedic that's a master's level that's going to be similar to the PA or NP, how would it look?
Well, I think if you're asking my opinion, which you are, I think it would look like, first off, they have to have experience in the field. Definitely would have to have a graduate degree of some kind, so a bachelor's. And then I would expect or hope that the master's would have clinical attachment along with a deeper understanding of pathophys, further differentials, and more advanced treatments. That should all be done in the context of on-hands learning and with clinicals, which is important.
So there's precedence. There's a master's PA, there's a master's NP, even though the NPs are trying to make you do a doctorate now to get their NP. So how would that be beneficial in pre-hospital? Like on this side of the pond, the paramedic can treat and release. There's no pressure at all to say, oh, you have to transport that stub toe. So the paramedics here can be like, oh yeah, sure, that's a stub toe. here's paracetamol and go see your GP. And so that would profoundly reduce your emergency department admissions.
When you say that, you're speaking of a EMS system that is, let's call it socialized medicine, and correct me if I'm wrong, but it's a more of a socialized medicine. So that EMS system is attached to the country, and it appears like there's a better understanding of protecting the entire system itself. When you get into EMS in the United States, you have a multitude of different types of EMS systems. Some are profit driven, some are tax funded. And I think there are departments that have treat and release, but as I was saying, it varies from county to city to state because there's so many, there's such a variance in EMS systems in our country. And I think one of the reasons is we don't have a good state representation for our entire country. It's broken up into states, and then from there you get into whatever the EMS is in that state. And that, again, we have multiple different styles of EMS. And I think that plays a big factor in what we're discussing with treat and release.
So in the U.S. system, you don't get paid if you don't bring them to the hospital. Is that correct?
Well, if you're speaking for the EMS system itself, that's mainly true. I think there's some new initiatives to get funding for treat and release. But as a whole, if you're talking about funding for the EMS system, yeah, you're generally recouping costs from transport and you're billing the patient's insurance.
What's interesting on this side of the pond, that we have, like the United States, we have bunch of different individual countries that can do whatever they want. They're not answering on the EMS system to what Brussels wants. So they create their own EMS, and it's based on their funding and their tax. Like the further east you go, there's fewer tax dollars, tax euros, and so they have to adjust. But every country I've been to so far, no matter if it's doctor-led or nurse-led or paramedic-led, all of them have what you would call a socialized system, but I call it a medical system, that they don't have to, they get paid regardless if they get treat and release. And there's vast different countries that do their own thing, but all of them are all paid by the government. So if we can do it, and there's more citizens in Europe than there are in the United States, if we can do it, why can't you?
So it's not that it's impossible. It's just that there are different barriers affecting that. So in the United States, state rights is very important. And so anything federally mandated or coming down tends to not be something like EMS. There are some, DOT has their stuff, but when it comes to actual EMS care, it is more states' rights. And so I think having a national system or the national registry even moving to an advanced provider would be great. What you're seeing happening in Kentucky with David Pfeiffer is, I think he is approaching it the way I think you should, which is you start at the state level, and then that becomes kind of a test bed or a first, this state did it, and then it kind of grows from there. But if I'm being realistic, we're a long way off from some sort of advanced practitioner paramedic through the entire country. We do have advanced practice medics throughout the country, but they're dependent on the system.
There's variance as well in Europe. So there are advanced practice paramedics or nurses in some countries, and some countries don't. Some countries have a nurse that can scoop and run, and if there's a BLS call, then they'll take it. But the dispatch, if it's an ALS call, will then send in a doc. Most of the countries here have a doc-led system, but Brussels is not telling each of our states to follow the line, to do the EU thing. So the states' rights here in Europe are very strong as well. So there are similarities between both sides of the pond, and I'm just trying to figure out why is it the United States hasn't embraced the same concepts we have in their EMS systems.
My response would be to go back to funding. So what is funding these EMS systems? And that question is broad. So we have tax-based. If I have a tax-based EMS system, we can use those taxes and allocate it for a program like that. If many systems in the United States don't receive taxes, and so if you're a for-profit or a non-for-profit, it's challenging to implement an advanced practitioner into something that doesn't have funding for it. And so selling that funding, showing data to show why it's important, I think we're making some gradual steps in that. There are systems that we can look at in the United States that are doing that. But again, I personally think it comes down to funding. And EMS is actually not an essential service. And so
Phil, what absolute trollop of a person came up with that idea?
Well, I don't know. And I want to please correct me and look it up if I'm wrong, but EMS in most places are not considered an essential service. So
that is mental.
So when we're looking at fire, police, EMS kind of gets this, they're kind of forgotten in the system of public safety often. Everyone knows police and fire. And again, sometimes EMS does fire in that system. But to my knowledge, it is not considered an essential service in many places. So a state could state that, but I do not, as of my understanding, it is not considered an essential service. So right there is a big problem.
That is a major problem.
Yeah.
And that won't change if you ever transfer all paramedics under the Department of Health. Mm-hmm. That doesn't necessarily mean it becomes essential services.
Correct. If we look at cities, like the city I work for, my department is tax-based. And so the citizens do have a say in what's going on, and we have ability to advocate for getting more resources. But that does not exist throughout the United States. That's actually very rare. And so, yeah, it varies significantly on where you are in the United States, what type of EMS system is going to arrive and take care of you.
So a state could choose to say, you know what, EMS is essential, and we are going to pay EMS out of the state funds regardless of transport or not. And then that will empower you to start treating and releasing, which will then free up the hospitals and save hundreds of billions of euro.
Yeah, essentially you could. States tend to move a little slower in that. And that's why what you see happening now in systems that are doing it, it's generally like local tax base. So it would be a city or a county that's allocating extra money. And we have data to show that diverting people from hospitals does save money, right? It keeps the beds open. We learned that during COVID. We took barely anybody to the hospital, to the point where they asked us to start bringing them again because we were holding everybody away from the hospital. There was no one in there. So there's definitely precedent set, and there's evidence to show that it works. It's getting people on board and getting funding. And that's very challenging in the U.S.
So you don't see a change. You don't see there's any way to fix this problem.
I'm not saying there's no way to fix it. I think, again, what Pfeiffer's doing in Kentucky, that's a good start. But I think in order for us to actually get something, we need some national support. So right now, that would be something like the National Registry. So the National Registry could create an advanced practice paramedic. But again, the National Registry is not necessarily an authority over licensure throughout the United States. And we get back to state government again. Many states don't require national registry. So going to an all national registry, or we can call it whatever, but going to a national license would be a good start, I think. And then from there, we could advocate for, EMT, advanced paramedic, paramedic practitioner, whatever you'd like to call it.
But then you have 50 states that then choose on whether or not they implement this paramedic practitioner.
Correct. I think representation is very important. And I think on a national level, and this is just my perspective as being a 25-year medic in the United States, I think we lack representation at the federal level. And so it's multifaceted. It's complicated. I'm not saying it's not going to happen. There's just significant hurdles that have to be dealt with before we have a national advanced paramedic license available.
So you have nurse practitioners at the moment that work under their own license, not under a doctor. Would it not be very simple to just start creating an EMS nurse practitioner level for people like you who have decades of experience? You're the only ones that can do this. So you go to nurse practitioner school and you get your NP EMS. Then you can come back and do your job. But now, can't you do everything what we do here in Europe?
As a nurse practitioner?
Yes. As a nurse practitioner, paramedic, paramedic practitioner, I don't know.
Yeah.
Whatever it's called.
Yeah, if they would be working under their own license, I would imagine that's possible. Can I go into the hospital and be a nurse practitioner because I went to school for a little bit and got some extra training?
Well, you can do that now as a paramedic, so of course you can.
So I think when we're talking about hospital and field, I think it's possible, but it depends on who it is. Nurse practitioners, the current status of nurse practitioning in the United States tends to be hospital-based. And I think we have a lot better resources we have people who would be much better being placed on that ambulance if they received more advanced training.
Not paramedics.
No.
Or just paramedics.
Well, just paramedics, but there has to be a significant field component, and I don't see that with nurse practitioners.
So the nurse practitioner as is. So if we created a nurse practitioner EMS, and it's still nurse practitioner, still licensed as a nurse practitioner, but now with your EMS subspecialty, you can then go back, work on the ambulance, and be able to have a solo practice and treat and release and hopefully reduce a lot of the backlog in hospitals.
Well, it can happen. I don't think it's enough to do throughout the entire country. How many nurse practitioners want to work in the field?
Well, it'd be none. It would only be eligible for people like yourselves that you have a decade of experience as a paramedic.
I see. Yeah. And so if I'm understanding you correctly, the reason to go nurse practitioner route is because they work under their own license.
And their advanced practice. We're talking about advanced practice paramedic and options to get the U.S. up to the international standard. So obviously, having our own Masters of Paramedic Practitioner is the way forward. I've talked to David Pfeiffer, and he's passionate about this. I'm passionate about this. A lot of people, I would say the grassroots movement would be profound, but we will never do this because we're DOT. Under the Department of Transportation, we have 60 years of EMS momentum that just won't change. And there's people making tons of money off of this system that will never let us change. So how about we do like an SF approach here or dodge this bollocks that's coming at us from history and create our own paramedic practitioner within the framework we have at the moment, which is nurse practitioner.
So I'll answer that by giving an example of my system. We do have a paramedic practitioner in our department. That's an actual role, but they're PAs. And so that has been used. It hasn't been used as a nurse practitioner, but my department has an actual rank or a job of paramedic practitioner. But to get that practitioner, you are becoming a PA. So you're getting that master's level training, just like in P. I guess when we really get down to it, it comes down to training. So what type of training are they getting and how are we applying them in the field? I can probably think of a large majority of calls that probably don't require a nurse practitioner. If we're using the level of training from a nurse practitioner to evaluate somebody further to allow them to stay home, I believe paramedics can do that now. We just have to have more training and more education. And this is awful of me to say, but I'm going to ask you, I believe a nurse practitioner probably makes more than the average paramedic in the United States. So my next question as working in the system is who's going to pay for that?
Yeah, so that's the difference. So in Ireland, we have advanced practice paramedics, APs. They're master's level. And they get more than a paramedic, but they're not getting 180 a year that the nurse practitioners are expecting, or the PAs. So you have a PA paramedic, which I think that the PA training pathway is far better for us paramedics than a nurse practitioner. There's alignments with us and PAs, and there's tons and tons of paramedics that eject out of our profession and go into PAs, and they're fantastic. So that would be an option. But what person would go through 2.5 years of PA school, $200,000 in debt, and then work at $100,000 a year as an advanced practice paramedic?
Bingo. And that's, again, we're coming back to funding. I agree with what you're saying. PAs tend to have a better education track to allow them to work in the field, rather a nurse practitioner. Now, I say that because I don't know. I know what PA training is more than nurse practitioner. All of our PAs in our department were prior paramedics. And so the PAs that are coming to my scene, I've worked with them when they were a paramedic. Nice. So it's very cool because you know what you need and you can call them and they know exactly what's going on. I don't think you'd get that with nurse practitioner unless they were a paramedic. And I think that's an important part is we can make a paramedic a nurse practitioner, we can make them a PA, we can make them a doctor if we want, but where do they get their training? Where are they coming from? Where's their core understanding coming from? And I think that is important when we're looking at pre-hospital. It's a very different environment than the hospital.
Yeah. So this whole concept of advanced practice paramedic could align with the PA, but the problem is whoever goes to that program could go and you become a PA or a nurse practitioner, and then you can work in cath lab and make $250 a year eventually as a PA harvesting veins. No one is ever going to come back to the streets. And let's face it, I'm pushing 60 and my back is rubbish. And
right there with you, man. I'm 45.
Paramedic is definitely hard on the body. So
I got an extra 10 years out of the power loads because, after I started, that's probably added a decade to my career. Yeah. And so let's, for argument's sake, let's talk about getting an advanced paramedic license in the United States. So I'm going to go to and this happens right now with specialty licenses, and I'm not comparing, an FPC to a PA, but if you have multiple specialty licenses, you're going to go to your employer and you're going to say, hey, I got all this stuff. And oh, by the way, I have a bachelor's, or maybe I have a master's, and the EMS service is more than likely in the United States going to say, that's great. We start paramedics out at this, and that could be a paramedic with a single paramedic license or a paramedic with 4 degrees. And so there needs to be a financial incentive. There needs to be pathways for that, and there needs to be funding. And that's what a lot of systems struggle with. The only reason my department has been able to do that is because we are a tax-based system. So we are funded by taxpayers. And I think that's an important part to this puzzle is funding.
Let's bring this back to this week. So you're here on the iCare, Intensive Care for Austere Remote Environments, as part of your 703 and 705 for your Masters of Austere Critical Care. So you're halfway through the Masters of Austere Critical Care. Is that a clinical degree that would meet some of these advanced practice requirements in the U.S.?
I would think so. There's significantly lots of pathophys, there's hands-on training, and there's also clinical placement. So I think if you're looking at maybe what would just be the basic framework, I think it's there. I think clinicals and hands-on and patient treatment is extremely important if we're going to go that route. Yeah, I think being halfway through the program, I could see how a lot of this could apply towards an advanced paramedic position.
So maybe there'll be master's level paramedic programs popping up around the world or popping up around the U.S. that is not EMS or leadership focused, that is actually advanced clinical acumen.
Correct. And I did check. We were discussing this earlier. I double checked to make sure. I do not know of any master's program in the United States that has a clinical application, and that's the reason I'm here. Don't want to be public safety administration. I like being out there and taking care of patients, and that doesn't exist in the United States right now.
So, Andrew, my final question for you is this: what advice do you have for the new medic, new nurse, new doc who is just starting out on their career in austere medicine? And you can tailor that to yourself and your own pathway.
So, for a paramedic that's already a medic and they're now interested in austere, you have to, let me think. So I think if you're going to austere, you need to find appropriate training first, because austere is a very specific subgroup of medicine. So you have to make sure you're getting educated by the right people. And then the next thing I would say is get ready to be uncomfortable. This degree challenges my thoughts on things, and I come to it as a street medic in the United States, and there is a significant amount of learning that goes into preparing yourself to work in an austere environment that we just don't get. Getting ready to get uncomfortable and learning lots of new stuff, and also challenging a lot of beliefs that you have with care, because when you're in a third world country, treatment is drastically different, and it's not just working in the back of the ambulance, much more than that.
That's good advice, and it's great to have you here for this week, and thank you for being a guest on our podcast.
Thanks for having me. I enjoyed it.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.